and today is going to be, the subject will be Boston Scientific Pacemakers, how to interrogate, and we'll also discuss about the main parameters to program, the things you need to know when you program Boston Scientific Pacemaker. You see here, this is the first screen. This is a patient, I don't know which one exactly, but with a dual chamber pacemaker, Boston Scientific. And this is the first screen when you interrogate the device, and you see that it's more or less the same for all the constructors. It's the same kind of information that you will have in the first screen. So if you agree first, you will see on the screen the system summary. Yes, with the patient info and everything. So if you click here, yes, you see there are different things that you can enter once you have implanted the device. Of course, the name of the patients. It's important to program the gender because when you will program the rate adaptive pacing, the parameters will be different if you have nominally, if you have programmed that you are a male or a female. So anytime you want to program the rate adaptive function, you need to enter the fact that it's a male or a female. For the indications, nothing special. If you click now on leads, the leads here, it's not the information are not entered. I think it's very, very important to know which kind of lead you have implanted, unipolar, bipolar, the kind of leads. So you can enter with the connection, all this. I think that's something I systematically ask the nurses to enter at the time of implantation. The implant data is important. If you want to have a reflection about the consumption of the battery, it's important this, and the physician you can enter or not. Okay, most of the time I ask the nurse to enter more or less all the information. It may help during the interrogation. So if you close, so the next step you see, you can interrogate the leads. So if you click on the leads, you see these parameters for the atrial lead and the ventricular leads. Something important, all these measurements are performed every 21 hours. Every 21 hours, you will have the measurements of the P wave and R wave amplitudes. You will have the measurements of the impedance at the level of the atrium and the ventricle, and if programmed, you will have the measurements of the pacing thresholds. For the amplitudes, if you click on ventricular, please, you see that it's performed every 21 hours, but if the patient is paced, there will be no modification of the pacing rate or of the AV delay to favor spontaneous activation. So if the patient is paced in the ventricle, you will not have any kind of measurements. If there are some measurements, then you will have the amplitudes. But remember that there's no modification of the pacing rate or of the AV delay to favor the entrancing conduction. For the impedance, what you see here is the measurements in unipolar or bipolar according to what you have programmed. If it's programmed in bipolar pacing, what you see is the bipolar impedance. Okay, for the pacing thresholds, we will see when we will have a look to the parameters. That's for the amplitude of pacing. You can program either either auto or trend. Trend means like it is here in the atrium. It has been modified, so it does not correspond to this patient, but the trend traduces the fact that the threshold will be automatically measured every 21 hours, but without any adaptation of the amplitude. Whereas if you program it auto, there's going to be, of course, these measurements every 21 hours with adaptation of the amplitude. If you click on it, you can program it off. Click on trend, please. You see, if you like this, yes, unclick, then it's going to be fixed without measurements. I don't think there is any reasons not to perform the threshold. Some patients may be symptomatic. It's very infrequent with this kind of measurements. They can be symptomatic at the time of measurement of the threshold, but for all the other one, I will program at least trend or auto. Okay, so if you close, yes, at least I would click this one. At this time, there will not be any adaptation of the amplitude, but at least there's going to be automatic measurements. It helps during the interrogation. So I think it's about the leads. So the battery now, if you click on the battery, you see here the informations. Something specific. There is no measurement of the tension. You cannot know the tension. What you will have is the time remaining. So it's a color coded. So when it's right, it means that you have at least more than 1 year before explantations. And the magnet rate depends on the color. It means that if it's white, it's going to be 100 beats per minute. When you arrive at 1 year before the replacement, then it will be in yellow. And then the magnet rate will be decreased to 90 beats per minute. And if you see it, I don't know if you can see it, but the last year is red, and it's 3 months before explantations, and the magnet rate will be 85 beats per minute. And at this time, there's absolutely no modification of the pacing rate. If at the end of the 3 months, then you will have a modification of the pacing rate. It will be decreased, and the magnet rate also will be decreased. Okay, the minimal heart rate will be 50 beats per minute, and the magnet rate will be decreased. Okay, so remember, color coded, initially white, then yellow, and then red. If you click on battery detail, there are different informations. Something that can be interesting is here this percentage. There is a comparison with what you have today with how you have programmed your device compared to a pacemaker with 60 beats per minute minimal heart rate, 2.5 volt, 0.4 milliseconds with an impedance of 500 ohms and with 100% of pacing at the level of the atrium and the ventricle. So here, for example, it's 94%. It means that how you are programmed, you will have a consumption of 94% compared to this, I would say, typical programming and with a high percentage of pacing. Sometimes you see that you have, let's say, 300% compared to this or 200%. It means that there is a high consumption. So you can understand that the consumption of the battery is very high if the percentage is higher than 100%, for example, compared to that. Okay, so if you close, pretty simple here. Okay, now for the event summary, if you click on it, you see, first of all, if you click, you need to show that that you need to click to see the events. That's a specificity. Sometimes it's not very intuitive, but if you want to see that, if you click here on top, I don't know, here you see, no. Okay, close. I will not arrive to explain it, but whatever. What you see that you have different informations. You see here the values on a duration of 1 year. It's programmed like this. It's 1 year. You see on top, and you see the different measurements. But if you wanna, you can modify for every patient the trends that you can see. For example, here you see the heart rate and the activity level. So on a duration of 1 year. But if you click on select trends, you can optimize patient by patient. You can select, for example, the parameters in terms of heart failure. If you click on heart failure and then close, you see it will modify the parameters that you can see on the trends. If you come back to select trends, something that's, if you click on custom, what you see here, if you click here, please, you have different options. And for example, you can see the sleep apnea. If you click on the sleep apnea, that's a specificity, the AP scan. You see here the values. That's a specificity of Boston device. It's the same for microport devices. There is a sensor which is called the minute ventilation. And since you have a sensor measuring the minute ventilation, you can have an idea of the presence or absence of sleep apnea. And I think that's something that's a specificity of these devices. And in some specific patient, that can be really, really interesting to know if there is a reason, for example, to test with a complete test if there is sleep apnea or not. Or you can see also the effect of active ventilation in a patient with sleep apnea. Okay. Now, if you click on arrhythmia logbook, so you see here, if you want to see all the events, you need to click. Okay. Yes, right here. That's what I wanted to show. You need to click there to see all the events. Okay. That's if you want to move on the time, you will have the different events all along the past year and previously. So there are going to be an EGM recorded and a maximum of 3 EGM for each kind of episode. For example, here it's rhythmic. If you click on the first one, the rhythmic, please. You see, if you were there last week, the rhythmic is the specific mode dedicated to decrease the amount of right ventricular pacing. And when you will have a switch from AAI to DDD, an EGM is going to be recorded. It's 20 seconds of at the time of switch from AAI to DDD. In this specific event, for example, if you can, yes, click and see, stop. You see, that's a real AV block. You see there is a block P waves. And you see there is a VVI backup pacing. The minimal heart rate has been programmed at 60 beats per minute. So you will pace at 45 beats per minute. So it corresponds to an interval of 1,333 milliseconds. And you see here 3 block P waves, so 3 backup pacing. And after 3 out of 11 ventricular cycles, there's going to be a switch to DDD. Okay. If you close the third one now, the third rhythmic, it's about the same, but you see here 1 block P wave, so a long cycle, and this cycle is spontaneous. It's a VS, but it's also considered as a long cycle. Remember that a long cycle is either a backup VVI pacing, so 50 beats slower than the minimal heart rate, or a spontaneous ventricular cycle if the cycle is longer for 150 milliseconds longer than the minimal pacing interval. So here in this patient, it's 60 beats per minute. So it's 1 second, so 1,000 milliseconds. So the ventricular cycle is longer if it is more than 1,150 milliseconds. This is the case here. So you have 3 long cycles. So there's going to be a switch to DDD. Okay, so I think that's very important. And that's, I think, an advantage compared to the other competitors because you can see and you can verify the switch, and you can verify that it has been appropriate or not. If you close, if you can show me a PMT now. Yep. This is a PMT. That's also a specificity. The only 2 constructors where you can see recorded in GM when there is a diagnosis of PMT are Boston and Abbott. You cannot see recorded in GM in Medtronic, in Biotronic, or in microports. That's also a specificity. That's also interesting because in all the other one, you will have a count of the numbers of PMT, but you cannot check if this is really PMT or if this is the wrong diagnosis. So in this case here, you see that first, the device is functioning with a very long AV delay. So I will show you, this is the search AV plus, search AV plus. The device will search for the presence of an entrancing conduction. And then at one time, after 8 beats, you will come back to the program AV delay. That's the case here. And then if you follow, yes, show all the tracing after 16 bits like this. VP-MT at the maximal tracking rate with retrograde conduction, there is a suspicion of PMT. On one cycle, there is a prolongation of the PVARP. The next actual cycle falls inside the PVARP here, and then it will stop the PMT. So I don't know if it's very clear, but what you need to know is first that there is a recording of an EGM in case of PMT. Second, that you will have, for a diagnosis of PMT, you need to be, the ventricular rate need to be at the maximal tracking rate. It will require 16 cycle VP maximal tracking rate AS, and after 16, there is no confirmation of the fact that this is really a PMT. I mean, there is no modification of the AV delay to check that if it is a real PMT or not. On one cycle, it will systematically prolong the PVARP. And in this case, that was a PMT. And with this prolongation, there is ending of the episode of PMT. Okay, so if you come back to the onset of the episode, you will see that in many cases, the PMT in this patient start because of the surge AV+, which will prolong on a few cycles the AV delay, and prolonging the AV delay, you increase the risk of retrograde conduction, and then you increase the risk of PMT. Okay, if you close. There is also an episode of, yes, at ATR, it means in case of atrial fibrillations. If you click on it, and you see that's the end of the episode here. I will not go too much into details on how it works, and I will show you when I will show you how to program the device. But that's an episode of atrial arrhythmia, and you see the end of this episode with reduction of the episode at the end. Okay. So if you close, so remember the specificity is that you need to click on top here to know where are the episodes. Sometimes you do not have the impression that there are episodes, but if you want to see the whole episode, you need to click on this. Okay. On the patient diagnosis now, you see here, if you click there, something I always have a look during the interrogation are the histograms. If you click on details, the value that you see here are the value from the last resets. So anytime I will finish the interrogation, I will reset. It's not possible on this because this is a recorded interrogation, but when you will click on end session, at this time, it will propose you to reset all the data, all the counters. So that's something important to do it. It will not eliminate the recorded EGM, but it will reset all the values in terms of histograms, for example. Okay, so you see here the data at the level of the atrium and at the level of the ventricle. You will see if it's spaced or sense. So you see at the level of the atrium and the ventricle. Important to know if there is an acceleration or not of the rate. And in this case, if there is a dyspnea in a patient, of course, that's data that we will immediately have a look. If the patient, say, is symptomatic during exercise, this is where I will have a look to know if there is or not acceleration during exercise. So if you close, Brady counters, if you click on details. So if you close first, first, you will see also the percentage of pacing or sensing at the level of the atrium and the ventricle. Now, if you click on details, something important is the amount of atrial fibrillations. So that's where you will find it here. You see here in this patient, you will know the percentage of time in atrial fibrillation and the amount of time. If, for example, you can see, for example, the patient has remained in atrial fibrillation for 2 months, 3 months, 1 day, 1 week. You see, so the total percentage, but also the amount of time. Something also I always have a look is the number of PVCs. You see here, premature atrial contraction, but also premature ventricular contraction. It's here. This is where you can find this information. Well, at least the percentage of atrial fibrillation. Anytime I will describe what I have observed during this interrogation. Of course, I will give information about the leads. I will give information about the battery, but I will also give information about the amount of atrial fibrillation. Okay. Tachycounter. Yes, the heart rate variability, that's not something I'm very familiar with, but I know that some physicians are really interested about these informations. The details, if you click on it. What you see here, the two curves are the comparison from the last measurements and what is called the reference, which was the previous measurements during the previous interrogation. And you can have a look and see if there has been variation from one interrogation to the other one. For example, if you have programmed something like red adaptive function, maybe you will expect, like in this patient, the footprint is, you see, from 14% to 30%. So there has been an increase. So it's supposed to be more physiological. Okay, I know that some physicians are really interested and have the culture about this information. That's not my case, but maybe it's important for some physicians. Okay, if you can close. And the tachycounters, okay, you can click on it, but you will see if there has been episodes of fast ventricular interval, fast VT on these kind of things. Okay, are there any questions? It's pretty much the same from one company to the other one. Here, what I will say is that one of the difference is in some specific patients can be very interesting to know the sleep apnea score because you have the information since you have the minute ventilation here. Okay, and remember, it's measured every 21 hours without modification during the sensing measurements. Okay. Okay, so now if you click on the tests, yes. So of course we cannot perform the tests today, but the thing that you need to know is that for the thresholds, you can ask for manual measurements, manual thresholds, so typical threshold, but you can ask also for automatic measurements. So you will have the possibility to check that these automatic algorithm with automatic measurements of the threshold are working correctly or not. So you can see it real time, and I think that's really interesting. Okay. For example, at the time of implantation, I will systematically perform this automatic measurement, and if it works correctly, then I will program either the train or the automatic adaptation. Okay, so now if you click on settings, you see here on the left, you have all the important rate that you will program, the minimal the lower rate, the maximal tracking rate, the VT rate. It means it's the time where it will consider that this can be a ventricular tachycardia. You can modify it directly on this screen if you want. See, you can change it. The same for the maximal tracking rate if you want. Okay, you can modify it. The atrial trigger is the rate for the diagnosis of atrial fibrillation. You can also modify it directly. Now, if you click on Brady settings, so what do you need to know? First, nominally, it's not a nominal programming here, but nominally it's DDD. And the rhythmic here, if you click on rhythmic, it's nominally programmed off. You see, so once more, it's AI with VVI backup pacing. This is the mode programmed to decrease the amount of avoidable right ventricular pacing. What is crucial is to know that you see here it's off, for example. So if you click on timing, if you can show us, yes, that's something very important to know. Close it, please. Close, yes. This rhythmic algorithm is working together with another algorithm. The rhythmic is the algorithm that allows the device to switch from AAI to DDD. But now, if you want the device to be able to come back automatically from DDD to AAI, you need to program a second algorithm. If you click on timing here, you see, and this is called the search AV plus. And this is the typical, I think, of wrong programming. This is exactly what you should not do. Nominally, the rhythmic is off. The search AV plus is off also. So if you program the rhythmic, you will program also the search AV plus. But in this patient, you see that there is a quite high amount of ventricular pacing. It means that probably the patient at one time is now in AV block. So we have deprogrammed the rhythmic, but we have forgotten to deprogram the AV search plus. And if the patient is in complete AV block, there is absolutely no reason to program the AV
Une
search.
petite seconde.
Yes, you can hear me? Yes. You don't want to program the AV search plus. Okay. So for example, if you remember, you have seen that there were many episodes of PMT, and PMT were induced at the time of prolongation of the AV delay. So first, if the patient is in AV block.
J'ai du mal vous comprendre. Essayez de me demander à nouveau.
Sorry, it's Siri that works. So the AV search, you need to deprogram it because there is no reason. You will not decrease the amount of right ventricular pacing, and you induce the risk of PMT. Okay, if you program it on the search AV plus, remember that the search AV delay cannot be more than 400 milliseconds, and the search interval is nominally on 32 cycles. So every 32 cycles, on 8 cycles, it will prolong the AV delay. So it's very, very frequent. If you program the search AV plus, every 32 cycles, it will prolong for 8 cycles the AV delay up to 300 or 400 milliseconds, according to how you have programmed it. So that's something quite important. And once more, if the patient is AV block, do not forget to deprogram, unprogram this search AV plus. Okay, we want to remain on this. The magnet and noise, you see, if you click on magnet response, that's something also you need to remember. There are 3 options. So pace asynchron, it means that you will increase the pacing rate, but there is also an option which is store EGM. And it's the same that in Abbott devices. If you program store EGM, it means that when you will apply a magnet on the device of the patients, it will not modify the pacing rate, but it will record a tracing. It's 2 minutes of tracing, so quite long. So it means that if the patient, if for any reason a patient is symptomatic and nothing is recording inside the memory of the device, the patient complains on, I don't know, about palpitation, but nothing is recorded inside the memory of the device, you can ask him to have a magnet, and when he's symptomatic, to apply on the box. And if you will have recorded EGM at this time. It's not frequent, but if a patient is symptomatic without anything recorded inside the memory of the device, that's something you can program. So you program store EGM, and then you give a magnet to the patient, he will apply it, and then you will see the tracing when he's symptomatic. Okay. If you close, we'll see only the main parameters to program. So we have seen the rhythmic, the lower rate, the maximal tracking rate. Maximal tracking rate is something very important in Boston device, since it will define the possibility to diagnose also the PMT. Once more, a PMT in a Boston device has to be, for being diagnosed, has to be at a maximal tracking rate. The maximum sensor rate is if you have programmed, of course, the rate adaptive function. The pace AV delay, you can program. You see like this. It means that I don't know any reason to program it like that, but there is no modification of the AVD, the pace or the sense AV delay from rest to exercise. If you want to modify it, you can, and then if you click it, you see you can program a decrease in the duration of the AV delay pace or sense AV delay during exercise. Okay. For the PVARP, that's also a dynamic PVARP. You can program it. It means that you will have a PVARP at the minimal tracking, at the minimal heart rate and at the maximal tracking rate. It means that you will have a decrease in the duration of the PVARP. The way it is programmed, it's going to be 400 milliseconds for a rate of 60 beats per minute, and it's going to be 300 for at the maximal tracking rate. It means at 110. The idea is to push the 2-to-1 point block. You decrease the duration of the PVARP to allow for more important 2-to-1 point block. Okay, and now what is important, of course, now in terms of pacing and sensing. Pacing and sensing, click, for example, on ventricle. Yes, auto. You have the choice between the trained, auto, or fixed. Okay, I don't know. I don't see any reason to program just fixed. I think you should program at least trained or auto. What you need to know is that the threshold is performed every 21 hours systematically, and there is going to be a verification cycle by cycle of the efficacy of the ventricular capture. So in the ventricle, it's more or less like in St. Jude's, in Abbott devices, it's something like, it's close to the auto capture. It means that you will perform the thresholds, and then on bit to bit, you will verify there is that there is a capture. When you program auto, you cannot program the margin. In the ventricle, when you program it auto, once more, it's something close to the auto capture. It will perform the thresholds, and then it will add a margin of 0.5 volt. The duration of pacing is, you cannot modify it, it's 0.4 milliseconds. If you program auto, it's going to be 0.4 milliseconds with a margin on 0.5 volts more than the thresholds. You cannot modify the margin once more. It's the same in Abbott. You cannot program the margin, but the margin is a bit less in Abbott. It's 0.25 in Abbott, and it's 0.5 in Boston. You can program the margin in Biotronic devices. For the Atrium, it's not auto capture. It's going to be auto sense. No, I don't know how to say it. You will perform the threshold every 21 hours, and then there's going to be an adaptation of the amplitude for the next 21 hours without verification cycle by cycle. So you perform the threshold, and for the next 21 hours, there's not going to be any verification of the capture. So now the margin is, of course, more important in the atrium than in the ventricle. There are some details. You cannot deliver less than 2 volts. You cannot deliver more than 5 volts. And it's going to be more or less 2 times the threshold measured. Okay, so for example, is at the atrium, the threshold is 0.5 volts, then you will deliver 2 volts because you cannot deliver less than 2 volts. If the threshold is 1.25, for example, then you will deliver 2.5 because you want to deliver at least 2 times the measurements of the thresholds. Okay, obviously it works quite correctly now inside the atrium and also inside the ventricle for Boston devices. For the very first versions of this algorithm, it was imperfect, I would say. Now it has been considerably improved, and I think it works very correctly. If you program at least trend, you will have an automatic measurement of the threshold. And anytime at the consultation, when you check and you compare the manual threshold and the automatic threshold, it's very, 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 very infrequent that there is a difference between these two. Most of the time, it's exactly the same values. So it works correctly now. For the sensing, and that's something very particular, nominally, this is the way it is programmed. It's programmed on fixed 0.5 millivolts in the atrium and 2.5 in the ventricle. You have the possibility to change the method. You can click on fixed or on automatic gain control, AGC. If you click on AGC, what you see here are the nominal value. First of all, if you want automatic gain control, it means automatic sensitivity, like in a defibrillator, you will have for both atrium and ventricle. It's either fixed for both or adaptive for both. You cannot say I want adaptive for the atrium and fixed for the ventricle, because it will have a direct impact on how you program on the different blanking at the level of the atrium or the ventricle. So it's either automatic gain control for atrium and ventricle or fixed for the atrium and the ventricle. But what you see here is that if you program automatic gain control, the nominal values are, for example, 0.6 millivolt inside the ventricle. So the device is now very, very, very sensitive, exactly like in a defibrillator, except that what you need to have on a pacemaker and a defibrillator is not exactly the same. On a defibrillator, you want to sense correctly a ventricular fibrillation. And the main task of a pacemaker is not to be inhibited in case of oversensing. So you don't want to be as sensitive, I think, in a pacemaker than in a defibrillator. And at one time, we were systematically, for any reason, programming automatic gain control also in a pacemaker. And we have seen that we had many problems, not many, but at least some problems of oversensing with inhibition of pacing, and it can be catastrophic in a pacemaker. So obviously, I will highly recommend to remain with fixed in nominal. Yes, if you click on fixed, like it is, that like this, I think most of the time you don't have any kind of problem. Sometimes I modify a little the sensing at the level of the atrium. I will decrease the value if there are problem of undersensing of atrial fibrillations. Now for the leads, nothing particular. What is different here is the rate adaptive pacing. If you program the sensor on DDDR, nominally, you will program, it's going to be the minute ventilation, and the accelerometer will be passive. It means that everything about read adaptive function will be based on the minute ventilation sensor. I think it works correctly. There have been some problem in some device with this algorithm, but now I think it works quite correctly, I will say. You can program both. You can program them together. If you program the accelerometer on, then there's going to be a mix of information between the minute ventilation and the accelerometer. So usually I let the minute ventilation on, and in some patient, in some old patient, for example, where the minute ventilation is not very reactive at the onset of the exercise, maybe you can program the accelerometer and you can program it both. You can program it together. You can select either accelerometer alone, minute ventilation alone, or you can, like this, program both accelerometer and minute ventilation. Okay, with the minute ventilation on, or at least passive, you will have the information about sleep apnea. Okay, so if you close the atrial tachycardia now, if you click on it, clearly Boston is the one where you can program the most, the higher number of parameters. There are a lot of parameters that you can program. Nominally, it's like that. Usually, I do not modify it. So if on the left of the screen, I do not modify these parameters. But remember that the way it is programmed, sometimes it takes quite a long time before switching from DDD to VDI. Okay, so remember that it's quite long. If you require a duration of 8 cycles, it means that before switching from DDD to VDI, there is first a need for the 8 fast, do not remember the details, about F fast atrial cycles, and then you need to have a natural arrhythmia that is maintained for at least 8 ventricular cycles. The duration corresponds to the episode have to last at least 8 ventricular cycles. So it's quite long, I would say, compares, for example, to biotronic or compares to Medtronic devices. But this is something you can modify. If you click on duration, for example, you can program 0. If you and try count, if you click on it, you can program 1. It means that if you want, but that's not something I will program, of course, but if you program like this, it means that after just one fast atrial cycle, there's going to be a switch from DDD to DDI. Okay, something important, and that's something I systematically modify in a patient with AV block, for example. The fallback mode is VDI, and usually if you click on it, I will, of course, program the rate adaptive function during the fallback. Okay, so VDI-R. So that's something. There are not so many parameters that are systematically modified in Boston Scientific devices from the nominal values, but this is one at least that are modified. VDI-R. Nothing special. Yes, for the atrial flutter response, here it's programmed on. So that's an algorithm I think that works perfectly, this one. This one is a very, very, very good algorithm, and it makes, it decreases considerably the time of ventricular pacing at a high rate when there is an onset of atrial fibrillation. When there is an onset of atrial fibrillation or atrial flutter, the problem is that before the switch, the patient can be paced at the maximal tracking rate for, like this, for example, 8 beats. But if you program this algorithm on, then on one beat to the other one, it will systematically stop pacing at a high heart rate. I could show you some tracing. It will be way easier to understand the way it works. But remember that this atrial flutter response is off nominally, and I systematically program it on because really it is very interesting in case of atrial fibrillation or atrial flutter. Okay, and then what you see here are algorithms designed to decrease the amount of atrial fibrillation to prevent the occurrence of atrial fibrillation. I'm not a big fan of this kind of algorithm. Okay, close. Hugo Pierre, anything to add?
No, not really.
No. Someone, any question? No. What could I say? I don't know.
Do we ever use the indications-based programming?
If you click on it, indication-based programming. Usually I don't.
Me neither.
No, you see that there are options that you can select according to the indication of pacing. Then it will systematically program one typical programming. Or okay, no, I never do it like this. There are not so many parameters that I systematically modify, in fact, compared to the nominal value. Of course, I will adapt systematically the maximal tracking rate according to the age of the patient or this kind of thing, the minimal heart rate. But at the end, the way it's programmed nominally, I do not modify systematically a lot of parameters. For the pacing, at least trends or auto. For the sensing, once more, I would really recommend to remain with fixed value in pacing dependent patients. Yes, because you may have problem of oversensing that you don't want if you program the automatic gain control. Remember that if you program the automatic gain control, then the device is very sensitive. It's as sensitive as a defibrillator, and remember that Boston Science devices are very, very, very sensitive devices. The defibrillators, you may encounter problem of diaphragmatic oversensing, of muscular oversensing, much more than in all the other devices. So I would not recommend to program it like this, particularly in patients who are dependent to their pacemakers. Okay, the minute ventilation, once more, it gives you information about the sleep apnea, and some physician, and I think it's right, this is not our culture, but that should change in the future. I think that this is an information, it works properly, so it can help for the diagnosis initially, and it can help also to know if any therapy is effective or not in terms of sleep apnea. Any questions? Any comments? No. Okay, so next week we're going to discuss about biotronic devices, biotronic PM. I think next week it's going to be the last about pacemaker, and if you agree, then we will do exactly the same for the defibrillators. We may start with subcutaneous ICD from Boston, and then with endovenous defibrillator from Medtronic, Abbott, and all the different companies. Okay? See you next week. Bye.